יש לנו אפשרות היום לשמוע מפרופסור מישאל סיילר את הנושא של Active Community Therapy. למה אנחנו עושים את זה בבית החולים? כאילו מדברים על הנושא של הטיפול קהילתי, לא טיפול בבית החולים. אבל מה שחשוב בטיפול הזה, שהוא כבר 40 שנה בשטח, שהוא מלקט את הצוות. הוא עוזר מה שהיום, ואתם מכירים, משרד הבריאות מנסה לקדם, הלקוח מטפל, ואנחנו עדיין חושבים שהמילה נכונה, חולה, הוא במרכז. ואנחנו כאנשי צוות צריכים לראות איך אנחנו מתארגנים ביחד, איך בונים שפה משותפת, כדי שאותו חולה יהיה בריא. גם לחולים מותר להיות בריא, גם לחולה מותר שיהיו לו חיים רגילים, בוודאי כמו כל אחד מאיתנו, עם ההגבלות, עם דברים נוספים, אבל זה המטרה, ויש לנו באמת הזדמנות לשמוע על הטיפול הזה, ומה שאני ממליץ לכל אחד, ובמיוחד לצוות של בית חולים שער מנשה, לנסות לראות איך אנחנו יכולים ליישם את זה בעבודה יום-יומית שלנו, ואיך זה גם יעזור לנו בקשר בין טיפול בזמן האשפוז, בין טיפול מרפאתי ובין נושא של השיקום. אז אני לא להרחיב כרגע, יהיה לנו גם דיון, ואני מזמין קודם כל את אורן, שהוא יחד עם פרופסור מקס לחמן, יזמו את המפגש, דאגו להביא את הפרופסור המכובדת ארצה. בבקשה.
שלום לכולם, ברוכים הבאים. אני שמח להיות כאן כנציג של איספרה ולערוך את היום הזה. Thank you, Michelle, for coming here and sharing your knowledge with us for the second time. The other time with ISPRA was 2010. I just checked that. It was on the IPS model, a vocational rehabilitation model. Michelle Salyers, PhD, is a professor of psychology at Indiana University, Purdue University, Indianapolis, where she directs the doctoral program in clinical psychology. She also directs the ACT Center of Indiana, a collaboration of academic and community partners, including researchers, administrators, clinicians, consumers, and family members who share an interest in recovery-oriented, evidence-based practices. She earned her doctorate in clinical rehabilitation psychology at the same university in 1998. She completed her clinical internships at Dartmouth Medical School and was NASM HPD Research Institute postdoctoral fellow at the New Hampshire Dartmouth Psychiatric Research Center. She is a mental health services researcher in the field of psychiatric rehabilitation, primarily focusing on implementing recovery-oriented, evidence-based practices. She has published over 140 peer-reviewed manuscripts and has had over $10 million in federally funded research and implementation projects, many of which focused on the assertive community treatment and illness management and recovery. A little bit, thank you, Michelle, a little bit about ISPRA. because some of you are not familiar, I'm sure, with the organization. So just a few slides to get the impression of the organization. ISPRA, the Israel Psychiatric Rehabilitation Association, was founded in July 2009, 8 years after the implementation of the law for rehabilitation in Israel, 2001, with the support of a foundation, Leslo N. Tauber Family Foundation, which supports us until today, by 12 founders, psychiatric rehabilitation leaders and stakeholders. It's consumers, families, entrepreneurs, and professionals, and other people. And the purpose is to contribute to the promotion of the PSR field in Israel. So what is ISPRA? A professional home for all stakeholders in the PSR field in Israel. An independent, non-profit organization devoted to the PSR field. Based on personal memberships, PSR practitioners, consumers, families, and others. ISPRA board includes professionals, consumers, families, entrepreneurs, community representatives, and others. And the vision of ISPRA strives for a future in which all people engaged in psychiatric rehabilitation will focus on the person and on his or her journey to recovery, based on personal needs, will, and preferences. ISPRA is committed to contribute and assist in creating a community which promotes this vision. Okay, that's the beginning. Thank you. I invite Michelle to give us the main lecture.
Thank you very much. I have this little microphone on here. Can you all hear me in the back? Yes. Okay? Okay, great. So thanks for the lovely introductions. I think I'm getting... Oren, is there a way to turn this one off?
Yeah.
When I stand too close, I get, or maybe this. If I stand too close, then it gets a funny sound. So today, where we're going, I don't want to stand too close. Are we okay? Okay. So where we're going this morning, I'm going to start with some very basics on what is ACT, Assertive Community Treatment, and I'll use the shortened version of ACT, and talk a little bit about the history, how it came about, and then some of the research on the effectiveness. And my understanding is that some of you already know a little bit about the ACT model. Some of you may be implementing something close to the ACT model. But I was told that maybe a lot of you don't know very much about ACT, and so I wanted to start with more of the basics. And then we'll have another break to enjoy the beautiful food. I've never seen so much lovely food at a conference. This is great. And then we'll come back and I'll talk a little bit more about how ACT and recovery philosophy might fit together, some of the criticisms of the ACT model, and then really have much more time for the discussion part later today to hear from you and to talk through how ACT might work in Israel and what it would look like here. So I will mostly talk for a little while, and if you have a question that's like a clarifying question, we can do that, but otherwise maybe wait till the end for the discussion part to have more of the conversation to make sure I can get through this. So I'll start with what is ACT, Assertive Community Treatment. And at its very base, it's just a way of organizing all of our services to foster integration and continuity of our care. And it's really compatible with other evidence-based practices. So if we think about ACT as a structure for services, you might add other services in it. You might do certain types of psychotherapy. You might do vocational rehabilitation. You might do family education. There are other services you can put in. So if we think about ACT as more of a structure of how we do services. And what the structure is it provides, first, multidisciplinary staffing. And this should be familiar for those of you who work in a hospital setting, and now we see more of this in community settings as well. But an ACT team is a team that includes a psychiatrist, one or more nurses, social workers, vocational specialists. These are people who will help you get jobs in the community. A substance abuse specialist usually, and other case managers. Often in the United States, we'll see a consumer on the team, a peer specialist, we call them, and I think you have peer specialists here as well, who are doing well in their own recovery and they can help. In the United States, this is not that common, but when we've done work in Japan, they always have a family specialist. So you might think about that here. Does that make sense to have a family specialist, so a parent or a spouse or someone who could work with family members? And they work as a team. So what that team means, they share caseloads. These are not my clients and your clients or consumers, they're all of ours. And so people on the team see multiple consumers, and those consumers see multiple team members. So we all know this group of people well, and what their needs and interests are. And the ACT team has daily team meetings. And when we think about meetings, they can take a lot of time. And so the idea of doing this every day for some people seems like too much. But the idea is that you have a short time in the morning, up to an hour, to go through the whole caseload to see who needs our help right away. And we're just kind of checking in on people, and it's a way to coordinate these services. Some of the original ACT teams would actually meet twice a day, once at the beginning and once at the end, to kind of coordinate. But now most teams just meet once in the morning to have that check-in time. Another key feature of ACT is this low client-to-staff ratio. And I apologize, I use the term consumer, client, and sometimes I use the word patient. In hospitals, we use that term still. But all of those mean the same thing, the person receiving the services that we're working with. So the client-to-staff ratio is small enough that on the team you can get to know people as the clients very well. So in a more traditional case management model, one case manager might have 40 or 50 or even 100 clients on their caseload, and you can't really get to know them and work with them very well. So this is a very intensive model where you have fewer people per staff member. As the title, Assertive Community Treatment, reflects, most of your services are in the community. About 75% of the time you are serving the person where they live, where they work, where they want to work, where they hang out in the community. And you're doing intensive, frequent contacts. In the ACT model, you might see people every day if they need checking in on their medications and how they're doing. You would certainly see them at least once a week, but often a couple of times a week to even daily. And we're doing assertive outreach, that's also in the title, so that I'll I'll explain in a little bit who ACT is for, but these were people who were not very engaged in services, and we often would have to go out to find them and to bring them into services. Often these services are used for people who are homeless or in and out of the jail system. So you're going out in the community and trying to engage people who might not otherwise come in for care. And the idea is to focus on symptom management and kind of everyday living. So people who have the most severe mental health concerns, how can we help them be successful in their own apartments or homes out in the community? And being available in times of crisis. So when we have people who have very severe illness, we need to be able to be in contact with them. If they call some crisis number and the person doesn't know them, they're likely to end up in the hospital and maybe have care that's not fitting their needs as well as the team that knows them. And so the idea is that the ACT team is the one who can respond to crises and perhaps prevent crises from building into a major issue. And the last kind of key element of ACT is an idea of time and limited services, that this team will work with consumers as long as they need them. In the U.S., there's often an emphasis on shorter care, that you would see someone for 8 or 10 sessions and transfer them or discharge them. For the ACT model, the team should be there for life if you need it. And there's been some research now about when do you graduate people, when do they move on. But the idea is that you have these time and limited services. So who is ACT for? As you can tell, it's a very intensive approach. It can be very expensive when you have these teams working together. So it's really not necessary for everyone who has a mental health problem. So what the ACT model was for is really it's reserved for people who have the most severe disabilities from their psychiatric illness. And so people who have been in and out of the hospitals, or in the U.S. we stopped using a lot of long-term hospital stay, and people would end up in the emergency rooms of hospitals. People who can't keep their own apartments or homes, that they would become homeless and get evicted and have a lot of instability of where they were going to live. People who are not engaging in treatment. If you have people who are coming to your center on a regular basis to engage in treatment, you probably don't need the ACT model for them. So these are people who really have a hard time engaging in treatment. People who have combined disorders, so substance abuse problems along with their mental illness. We have often had very different systems, and people kind of fall through the cracks on those. So having dual disorders. Legal problems, we use that term forensic populations, but people who've been arrested, they might be in and out of the jail or the prison system. We have a term, not guilty by reason of insanity kind of thing, where they don't go to jail, but because they have mental health conditions, they need more intensive care. And then recent discharge from long-term hospitals. So I know we're on a beautiful hospital grounds here. There may be people who have been here for a very long time, and if they want to rejoin the community, how do we support them best? What can that look like? So this is really who the ACT model was developed for. So kind of the history of ACT and why was it needed. And this started in the 70s, and I'll talk a little bit more of that specific history. But I wanted you to think about what services looked like then, where we are, and why this model developed, why was it needed. And to think about, are these issues here? So that when we talk later today about how might ACT work, it'd be nice to know, are these things that you're seeing, or have you already fixed these things? So, and I'll go into each of these a little bit. The first one is this idea of fragmented services. So back in the 1970s in the U.S., mental health care was provided by lots of different places and little pieces. So you would have a hospital for kind of the more severe treatment, a mental health center in the community. They didn't always work closely together or coordinate, so you had those different places. We had a place where you could go for vocational rehabilitation, so if you wanted to get a job or go back to school, and they didn't always talk to the mental health centers. In the U.S. we call it Social Security, but kind of that state insurance that would pay for benefits, housing services, food stamps. There were a lot of different places that people with mental illness would need to talk to or get help from, and they weren't talking to each other. And when you have a disorder that really affects your ability to organize your thinking, or symptoms that interfere with your ability to be assertive and talk to other people, it's really hard to get all of those services coordinated. So we had the fragmented services. We had episodic treatment, that people would come into the hospital, they would get care, and then once they stabilized, it was kind of assumed that they're good to go. So they've been stabilized, we'll release them. But then once they were out in the community, they didn't necessarily continue their medication. They didn't necessarily continue the intensive therapy that they might have had in the hospital setting. And so they really didn't have a very continuous treatment. So they would get very minimal treatment until there was a problem, and they would have its recurrence, and then they would go back into the hospital. And a lot of people really kind of slipped through the cracks, that they didn't really connect very well with the outpatient services. If you got into treatment because you had some kind of a crisis, there was a suicide attempt or something, and you ended up in the hospital, they often didn't get connected with that ongoing community of care. And so they would end up perhaps being homeless and not trusting people. They might end up in the jail system. So they were really not getting served by our mental health system. And then we would see revolving door clients, that idea that you would come into the hospital, get kind of fixed up, be doing okay, get released, and then things would kind of deteriorate and you'd end up back in the hospital again. And so our hospitals were seeing the same people coming back over and over again. And so the ACT model was really designed to address all of those issues. So it fixed the fragmentation by having a single point of responsibility. This team would help you with your substance abuse, they would help you get a job, they would help you with your insurance benefits, they would help you with your medications, in finding a place to live, they would help you clean your apartment so that you could live in it, like everything that team would do. So that really helped with the fragmentation. The continuity of care helped with that episodic treatment. It made sure that the same team was working with you. And if you needed to go back to the hospital, the team would help coordinate that and be ready to take you back when you got out of the hospital. So it was really providing that continuity. The slipping through the cracks could be solved by ACT because they would go out and try to find people. They would go under bridges to homeless shelters, to places that people would hang out and might not be engaged in care, and try to help engage them. And then they worked on the concrete needs that people have. So taking your medications and doing your therapy homework is important, but also the very basics of what is it you want in your life to make your life meaningful, and helping you address those things. Working with families, community, those kind of issues. And so it was really developed in the 1970s, and they published a kind of groundbreaking paper in 1980 on the ACT model. And it was really in response to, it was a group of people in a hospital, a long-term hospital, who developed this model because they were seeing the same people coming back. and that they would do a good job helping people while they were in the hospital, but once they were out, things sort of fell apart. So what they did originally, they called it a hospital without walls. And the idea was that they took that same structure that we had in the hospital setting with the multidisciplinary teams who would have staffing meetings in the morning and they would check in on people. So the idea was to create that sense of structure, but then put it out in the community so that they could serve people outside of the hospital. And they also called it the training and community living model, and the training part is important. How do you teach people to live in the community? That teaching people how to cook on a stove in the hospital is great, but if they go out into the community and have a different kind of stove, they weren't able to transfer those learnings. So they really thought you had to teach people how to live in the community in those community settings. And this paper was really important because it experimentally showed that it was a very effective model, that people who got ACT stayed out of the hospital and had much more successful outcomes. So that was really important. And over the years, you will see different labels that kind of mean very similar things. PACT is the Program for Assertive Community Treatment, and then ACT is kind of the smaller acronym. Some of these may vary a little bit, but they have a lot of the same core features. So when you see these labels, they're talking about very similar kinds of things. So the growth of ACT, after that paper came out, people were very excited about ACT. And we had some states that we call early adopter states who took their whole state system and said, we're going to do ACT. So in Michigan we saw it, in Chicago we saw it. Some of the bigger states, or mostly small states first, and then in the 90s, some of the bigger states. And then we started having a real shift in focus in the late 1990s and early 2000s on this idea of evidence-based practice. And because ACT had so much research behind it, all across the country, states were saying, well, we should be doing this because the research shows it's effective. And so there was a lot of training centers that were set up, a lot of places that would go out and help people do the ACT model. And so when Oren read my background, he said I was the director of the ACT Center. That's what we did for many years in Indiana, was to go around and set up different teams and do training and visit them and make sure they were doing it all right and being helpful to them. And we started seeing growth in lots of other countries. And so we've worked with Japan and the Netherlands in particular, but a lot of other countries are doing ACT. And then in the U.S., we've had some kind of backsliding in the recent economy. So in 2010, our state changed how they funded community mental health services, and that actually took away a lot of our ACT teams. So at the height of our ACT teams, we had 32 different teams, and then a year later, it went down to 4. And that was really sad for us to see, because that was a whole system, and we were seen as leaders in ACT, and then our state had to change the insurance. And then, for a while, we were excited with Obama, and we had Affordable Care Act and Obamacare, and it was going to make mental health and substance abuse equal to physical health, and that there would be more services. And so we were excited, thinking this last couple of years that we would see more ACT teams and it would have a resurgence. But then we had an election in November, and things have changed, and now they want to take away Obamacare. And the more recent things they've said is now they don't even want to fund mental health at the same level. And so I'm really worried. I don't know what's going to happen in the U.S., but I think people will find a way to do what they can with some of the elements. So that's kind of our history of ACT. And to get into a little bit on the effectiveness, as I mentioned, ACT is considered an evidence-based practice, which means it has a lot of research support behind it. In one of the early reviews, Gary Bond, who was my mentor, he trained me, he reviewed 25 controlled studies. So the controlled studies meaning these were randomized controlled trials where people had either got ACT or something else, and they had an equal chance of getting those services, and then they were followed over time. So these are the most rigorous studies, and in those most rigorous studies, we found that people who were in ACT had a lot less inpatient hospital use, so it was keeping people out of the hospital. They would report higher levels of quality of life, so they felt better about themselves. They had more independent living, so that they would live in their apartments or homes, either with themselves or other people, but not people who were taking care of them so much. So they had much more independence. Better substance abuse outcomes when you had a substance abuse specialist on the team, and that was important. You needed to have someone who was designated to really help with substance abuse issues. And the same thing we saw with employment. If you had attention to supported employment and really this model of helping people get jobs and had a vocational specialist devoted to that on the team, then you would see better employment outcomes. So you had to really focus on that. And consumers and family members were much happier with the ACT model, that they really liked the support that they got. So those were the positive outcomes. And since that big review, there have been lots of other reviews that have looked at ACT. And most of the time, they're still finding a reduction in hospital use and stabilized housing. ACT is expensive. So if you think about that morning meeting where you have a psychiatrist and the nurse and all the professionals sitting around for an hour, they can't bill for that time. And so it becomes a very expensive model. And you're also doing assertive outreach. You're going out in the community. In the United States, we couldn't bill for that time because you have to be with a client or actually helping the client to bill for the services. So for mental health centers, it would be an expensive model. But we did find it was cost effective if you were targeting people who were high service users. So the people who were in the hospital a lot or doing the revolving door, that even though the model was expensive, it can save you a lot of money because you're preventing all of that expensive cost. And as I mentioned in our national project for implementing evidence-based practices, it was one of those highlighted areas. So a lot of states and systems were very interested in it, and it became very widely implemented in the U.S. There are some kind of breakdowns in dissemination, we call it, where we're trying to implement the model, but it doesn't always work well. And some of those areas are really people would confuse ACT with other models. Often they would say, well, we already did that here and it didn't work. Or they would be using parts of the model, but not the whole model. And then they would say, well, it doesn't really work because we're doing this. But then when you would talk to them and go in and see them, they were only doing some aspects of the treatment model. And you might just choose not to do parts of it. So some places we were finding weren't really implementing it because they didn't want to or they didn't agree with it. And then some is just kind of a natural implementation drift. And so if you think about the very first model, there's a lot of attention and everyone's working together and they're thinking about it. And then you train someone else and maybe they only get kind of parts of it and they do the best they can, but then each generation kind of got away from the model. So that led people to start thinking about fidelity, following the model. What are the core elements of the model, and how can we help make sure that people are doing those core elements? How do we measure that? So the purpose of fidelity assessment is really to assess how well are we following a specific model. And this is not just with ACT, but any evidence-based practice. When you develop something like cognitive behavioral therapy for a certain type of disorder, you want to have a manual, you want to have some way to measure if people are doing it well. And so that's what we're doing with the ACT model. And the basic fidelity scale has 3 different subscales that we look at. So we look at the staffing patterns, and I'll go into each of these a little bit. But who do you have on your team? How do you organize the team? And then what services do you provide? And when we do fidelity assessment, we usually have some outside person or people come in and spend time with your teams. So if you were doing an ACT team here, I might come with a colleague, someone who has some experience with ACT teams. We spend the day with you, sometimes 2 days. We'll interview you, we'll look at your charts, we'll go out on visits with your consumers. We might talk to some of your consumers, and then we fill out this rating system, and then give some suggestions for how you might improve or what areas you might look at. And so we did this a lot with when we were help setting up those teams across the whole state. We would do these fidelity visits. And so the first area is the staffing. And so some of the things that we talked about on those first early slides, each item would have its own thing. Do you have a small caseload? So in order to get a 5, you had to have no more than 10 clients for each staff member that you had on the team. Are you doing a team approach? So do you have shared caseloads? Are people seeing each other's members? Are you having daily team meetings? And so a 5 would be you're meeting every day, and a 4 might be 3 or 4 times a week. And so we would rate people. Do you have a identified team leader who can help organize the team? Do you have continuity of staffing? So one of my other areas of research is around professional burnout and turnover, and we see a lot of turnover on teams. So in order to get high fidelity, we want to see that you have the same people over time and that you're at full capacity. So if you're missing positions on your team, if you're supposed to have 10 people on your team because you have 100 clients, but 2 of those spots are empty, then that really affects how you can provide your care. And then making sure that some of these key components are on your team. Do you have a psychiatrist a certain number of hours a week, a nurse, those kind of things. And then we look at how services are organized. And so do you have explicit admission criteria? So ACT's not for everyone, right? So how do you identify who's going to be on your team? Are they people who have a certain number of hospitalizations or people who've been in the jail system, but having some kind of explicit admission criteria. Having a small intake rate. You don't want to start an ACT team and bring on a whole bunch of people at once. You want to slowly build up your team so that you can get to know people and provide those intensive services. Are you providing all of those services yourself as the ACT team? Are you doing crisis services directly? So all of these elements are important. These hospital admission and discharge, the ACT team really should be coordinating with the hospital. Once you set up these ACT teams, we still need hospitals. We still need times when people can have that intensive care. But what the ACT team can do is help coordinate that and make it a less stressful time, maybe shorten the amount of time you're in the hospital, because we know that this team can step in again when you're ready to come back out. So it's making that transition smoother. So you get a score of 5 if the ACT team is really highly involved with admission and discharge processes. And then time unlimited services, that ACT team shouldn't have a restricted time. So there's a model that has some similar structural things to the ACT model called crisis time, CTI, crisis time intervention, critical time intervention. And it's for people who are homeless and coming out of the homeless shelters, and they would have this ACT team, but they would only serve you for 9 months. It was a very time-limited kind of approach. And so that wouldn't be ACT, because then you would have to transfer people to a new team, even though they had some of the same elements. So ACT is really that you can stay on as long as you need it. And then the last area of fidelity is thinking about services. Are most of the services provided in the community, or are you expecting clients to come into the center? And so for ACT to get a high score of fidelity, you should be seeing most of the people in the community most of the time. You should have a no dropout policy, and after our break, that's one of the criticisms, is ACT too aggressive, too assertive. If people say, I don't want your treatment anymore, I don't want your services, at what point should the ACT team let go? And how does ACT balance with recovery? And so we'll talk about that after our break later. But that's one of the issues is for high fidelity teams, we want to make sure that you're keeping people engaged. This assertive engagement, as I mentioned earlier, are you out there talking to people when you first tell them about how ACT could help them and they say, no, I'm not interested? Well, if you just go away, that's not really assertive community treatment. We want to see that you're out there and you're trying to engage people and you're talking with them a lot. You're using different mechanisms to get them involved in treatment. And again, that becomes one of the issues that we struggle with on recovery concepts of when do people have the right to say no and what does that look like. So we have to kind of work through some of those things. ACT services are intensive, and so if you're seeing people once a month, that's not ACT. Really, that you're seeing people at least once a week, and some people may need even more frequent services. And so you get higher fidelity points if you're seeing people more often. And frequency of contact. So intensity is like the amount of time, and this is how often. So when you're doing ACT, if you're doing real skills training, if you're helping people learn about shopping, setting up their apartment, how you cook in the community, how you get along with your neighbors or your families, these are not like 15-minute check-in visits, right? You're not just going in. You might go in, make sure they got their medications, but you're helping build skills. So you're spending much more time with people. So we're also looking at the amount of time as well as the frequency. And then are we using their support system? Are we engaging family members, other people in the community that they might be looking for, so that we're working with the natural community as well? And then integrating substance abuse treatment. That this was a hard one for a lot of agencies in the United States. For a while we had these separate, still substance abuse over here, mental health treatment over here. And so does the team have someone internal to the team, a specialist who can address that directly, is important. And so what we found with teams, teams that will score higher on fidelity, we did one study looking at, or Greg Teague did a study looking at ACT teams to different types of case management. And he found that that ACT fidelity scale did differentiate between other teams, that the ACT teams did have higher scores. And we can use fidelity scales as kind of a quality improvement tool, that we can help teams think about goal setting. It gives you a focus. If you decide you want to do an ACT team, then you can look and see, well, what is a score of 5? If we were the perfect ACT team, what would that look like? So it might help give you some goals. It helps teams understand the practice. So when you say, oh, we've been doing ACT already, but you look at the fidelity scale, you might see, oh, well, we weren't really doing that part of the model. So it can be a nice educational tool. It can be a nice political document. So if you're a team leader and you're working for an organization that maybe isn't supporting you as well as you need to be, you can take that fidelity scale and say, look, if you really want to do the ACT model, we're going to need a substance abuse specialist on our team. I really need that extra help. So we found that when we used the fidelity scale with teams, it could really help them get what they needed from their administrators to make changes. And it also provides some validation to teams. If you're trying to do the ACT model and you're getting some feedback that you're doing it well, that feels good, right? So it helps people want to do that more. And we also have found in the research that teams that score higher on those fidelity scales tend to have better outcomes. And so this was a study that we did in the 90s that looked at the correlations between higher fidelity scores and reduced hospital use. So at the team level, teams that had higher fidelity scores were much more effective in keeping people out of the hospital. And in particular, the staffing subscale and the organization subscale tended to have the stronger relationship with better outcomes. So do you have all of those staffing and the services? And then Greg McHugo did a study on people with dual disorders. So he looked at people who had mental illness and substance abuse treatment in 7 different mental health centers. And then he split them up into the programs that had the really high fidelity versus the low fidelity, and then studied them over 3 years. And this is kind of dark, but the high fidelity teams had far fewer dropouts, only 15%, to the low fidelity teams, 1/3 of their clients left. They had much higher substance abuse remission, so people who were no longer having substance abuse problems. The high fidelity ACT teams, 58% of their clients were in remission from substance use. Low fidelity was only 13%. And the high fidelity teams had much lower hospital admissions. So by looking at the fidelity of the programs, they're actually having much better outcomes as well. And so our working hypothesis is that better implemented programs then would have better outcomes. And I did a study when I was a graduate student about staff burnout in our ACT teams. And the ACT teams had less staff burnout than traditional case managers, even though they were seeing people who had more severe mental health problems. And we think part of that is that idea that a shared responsibility, the team is working together, and so you might feel less stress as a clinician. It's less personally responsible when you work for a team. So there's always a tension when you talk about models of care and fidelity. So we know higher fidelity teams tend to have better outcomes. But when you're doing a program in a new area, a new location, a different context, what do you need to keep and what do you need to change or adapt to make it work in your setting? And so Leona Bachrach says that really local communities know best and that local communities need to decide how to implement. And that all program models don't necessarily generalize to every community. But the people who develop the models really say that there are some core elements that you have to do in order to make it work. And if you adapt it too much, you might take away the key things that are affecting the change, right? And so you don't want to dilute the model. You want to try to implement as much as you can. And so Dean Fixton and his colleagues, when they wrote this implementation research guide, he suggests first do it right, then do it better, right? So you got to try it out as the model was intended to see if it works. And then if it's not working, then you can kind of tweak it and kind of adapt it for your setting. So that's kind of the recommendation, is to try the full thing and then do it better if you need to. So that's kind of the end point. So now I want to kind of stop and see, we can have some question time. I think we have time before we were going to take the break. So we have more time for discussion now, and then, or questions, and then we can have a break, and then we'll do some more lecturing and discussion too. So questions? Yes?
Things I would like to clarify. First one is the second question. You're talking about a facility in which people just come to get service, or you mean reaching out to people and visiting their houses and doing the rehabilitation or even part of the therapy there? That's the first question. And the second, you're talking about mixed responsibility of the team members, right?
Mm-hmm.
So, and it's talking about the ratio of 10 to 1. So if you have a patient, or let's call it a client, that is both treated for substance use on one hand, and let's say gets some kind of therapy by the psychiatrist on the other hand, is it the same case? Is it the same ratio? Is you consider the case both of the psychiatrist and the substance abuse? How does it work?
Okay, that's great. So your first question, if I understand right, when you're doing the rehabilitation and the intervention, it's mostly in their communities, in their apartments, rather than the mental health center. So the idea is that if you need to teach someone how to manage their budget, you might go shopping with them. You might look at their bank statement and help them balance the bank statement, all in there where they live. The second question is really interesting. So how do these teams work together? The 10 to 1 caseload ratio is an overall number. So if I have 10 people on my team, I don't want to have more than 100 clients for the whole team. Not all of those 100 clients are going to have substance abuse problems, right? So the substance abuse specialist, part of his role is to train the other team members how to deal with substance abuse. Because if 50 of your clients have substance abuse, I, as the substance abuse counselor, can't see all 50 of those people only and always see them, but I can help you as a case manager or as a nurse to learn about how do we talk about substance abuse, so that if you go on a home visit and you see that someone has been drinking the night before, what kind of conversation can you have with that person? How can you deal with this? So part of having those specialists on the team are to help other team members know how to talk about those things. Same for employment specialists. There might be a few people that are actively searching for jobs, and I might be the employment specialist helping them. But everyone on the team should be able to talk about your goals and whether or not you want to go back to work and supporting those things. So you might share the visits, but you're also sharing your expertise. Does that help? Good. Those are very good questions. Yes?
Why didn't you treat the homeless people?
Why?
Where?
Oh, where?
Yes, because you said in the community.
In the
their
community.
Houses and
Coffee shops, walking on the streets together. They would often be at shelters, and so they would go and meet people at the shelter. They might look for places to live together. They might look together for places to live. The case manager wouldn't live with them, but So they might be looking for apartments or places that they could live. And so they would mostly do that out in the community. Yeah?
I've noticed that the psychologists are not necessarily part of the teams. So I want to ask how much psychotherapy is one of the essentials focuses of this.
Yeah, that is very interesting. So in the U.S., our psychologists are more expensive, and they tend to be in, if they're in a community mental health center, they're in more leadership positions. And the people who are doing therapy are often masters trained MSWs or family therapists. So our psychologists are often doing assessments or administration. But I think psychologists can have a very important role on ACT teams. And so if they are part of your treatments group, or if part of a community mental health center or in the hospital, they can be on here. And I think therapy can be very important. So, but often it's done by MSW potentially or something like that. But I'm trained as a clinical psychologist, and I think having a clinical psychologist on your ACT team is a great thing, that you can do more therapy, you could do work with families in different ways, and so I think you can do that. I just think in our system, they're funded differently, and so they tend to have different positions, I think. Yes?
I would like to ask the same questions about occupational therapists.
Yes. Well, the original PAC team did have occupational therapists, and so we do see some of that. Most of our occupational therapists, I think, are in institutional kind of settings. And so with the first teams, they did have occupational therapists. And I agree that that is a good thing to have on your ACT teams. Mm-hmm. We would often think of them as maybe the vocational specialist too, but yeah.
Good morning. A couple of questions. Who are you funded by? Perhaps I missed it. And how is it going to continue now that you're very scared that Donald Duck Trump is going to cancel all the programs?
Yeah. So in my role now, I'm a professor at a university, and so my main job is to do research and teaching and training at the university. So are you asking how I personally am funded, or how the ACT teams themselves?
How the ACT teams are funded?
The ACT teams, yes. They are still funded by Medicaid primarily, which is our government insurance. In the United States, Medicaid has federal rules, but each state or region interprets them differently. So some states still have a lot of ACT support. You can find ACT in Washington and Florida, and so some states still are funding a lot of ACT. But in Indiana, our state went for a more office-based group interventions, and so they're doing more skills training in groups rather than individually in the homes. So you still have support, but maybe in different parts of the country. It's not a unified funding. Yes?
Have you ever experienced with already existing services that want to adapt the model?
Yes. So that actually happened a lot in Indiana when we were setting up those ACT teams. And it becomes, it's a philosophical shift for many people. If you're used to seeing clients in your office for 50 minutes and then they go, and now the ACT team we're saying, well, really you should be in the community. You should go visit their apartments. You should help them with everyday skills like budgeting and shopping and those kind of things. There are some people who didn't like that model, that they weren't trained for that and it didn't really fit for them. But other people loved it. They liked the freedom of going out into the community, of getting to know people in a different way, working with people more closely and seeing those things. So I think it can be a difficult shift for some because you're mindset and what you're used to, but some people really love that new model. So I think if you're taking an existing team and shifting it, you need to think about kind of plan ahead. What will it look like? How will people adapt to this? What will work best? Maybe someone might be a great employment specialist and really able to go talk to community employers, and you might get that person some specialized training to do that well. And someone else might really want to focus more on budgeting and those kind of things. So I think you have to think about that. And people can feel some threat, like if the leader of the organization says, now we're going to do ACT teams, then, well, what does that mean about me? And so when we would go into agencies and talk about ACT, they were worried they would lose all their clients, or that how would that work? So I think organizations have to have those conversations and be open and talk about, well, what will this look like? If we move these clients to this team, what does that mean for your relationship with that client? And what will that look like? So you do need to think about that. And I actually have other slides, not today, but on how to think through those things if you're shifting from an old team to a new team and you're going to do things differently. And I'm happy to share those materials with you, and you can share them with other people. So, yeah.
How does a day, one day in a professional in the team looks like? Can you draw?
A picture of what a day in the life of an ACT team. Actually, I think our website might have a video like that I can give you connections where you can download a video and they follow people around. So if you are an ACT team, you'll start in the morning. I don't know when you start your services here, but maybe 8 o'clock. You would have your morning meeting from 8 to 9. You all sit around the table. In our teams, usually the team leader, the identified kind of manager for the team, tends to be the master's level social worker, might be a psychologist. That person manages the group of people. The psychiatrist is part of that meeting, and he or she is kind of the leader of the psychiatric treatment and kind of the medical knowledge, along with the nurse. And then you have all of the other people around the table, and you'll go through your cards of all the clients to see very quickly. They'll check on every name, and so they'll say a name of a client, you know, Joe Smith, and someone will say, oh, I saw Joe yesterday, he was doing pretty well, he's set up for this appointment later this week, and then they move to the next person. Oh, I saw Mary, she's not doing well, she started drinking again, and she's having problems with her husband. So then if Mary might need more time to talk about, we might put Mary to the side and then go through the rest of the caseload. And then if people need to go out into the community and see their clients, but we need to talk about Mary, maybe a smaller group of people could spend some time talking about Mary and what could we do today to avoid this crisis. And so they'll have that kind of planning. And then everyone, they kind of figure out their schedule for the day, who's going to see whom, and they'll split up their day and kind of go out and see people. And there's usually someone who stays back at the office who is kind of the coordinator for the day. So someone calls in and they try to find Mary and she's not at her apartment, or she can't be found. Then they might be able to coordinate with someone else or those kind of things. So there's usually someone who stays back and kind of manages that. The psychiatrist, often the psychiatrist still sees people in the mental health center, but psychiatrists often will go make home visits, and they like that often. They like that freedom, and to be able to see people in their own environment can be very eye-opening, right? So what does it really look like there? What kind of stressors are they trying to manage? And so some of our psychiatrists really like going out and making home visits. And others maybe stay more in the organization, but then the case managers or other people bring the client in and can kind of report back to the psychiatrist what they're seeing if that person isn't in the homes. And the nurses do a lot with medication education as well, and they also deal a lot with physical health issues. So often our clients have a lot of physical health concerns that may not be getting met. Even with medications, we may have side effects like weight gain and high blood pressure, and so dealing with education around diet and exercise and those kind of things as well. Coordinating with going to see your physical healthcare doctor in the community. You might have a case manager that will take you and work with you while you're with your doctor. So they do all kinds of things. There's like, it's not a boring job at all. Every day is different. But you can have a lot of things.
How do you do outreach?
So doing outreach, people will go and maybe try to have coffee with people, try to have conversations. Sometimes, especially when you're dealing with people who've been homeless for a long time, there's a lot of distrust, like, who are you, what do you want from me? And so it may take a lot of different attempts to get to know people. And so often buying a cup of coffee or a little treat and spending time just getting to know who they are, what they're interested in, and not really focusing on the mental health part, but just getting to know each other as people. And I think that happens a lot. Getting to know what they're interested in. So they're interested in music, then can you go to a music store together, or can you go to the park where you know someone is going to be having a concert, or things like that. Playing basketball, one of the teams we worked with, they were trying to do the illness management training on their ACT teams, and had clients who really couldn't sit for long periods of time. So they would actually be out there playing basketball with them, talking about their symptoms and coping and things like that. So it's very different for different people. Yeah.
You mentioned it a bit earlier about just like borders of responsibilities between different team members. So the occupational rehabilitation or therapist, would he manage also like budgeting or house work and stuff like this? If he's like the connection with the client is well with him.
Yeah. So you have specialists who then also become, like, we call them the jack of all trades. So I might be the employment specialist, and I should be working on employment primarily, but maybe when I get to your house it's a mess, and I need to help you a little bit to do
Not
that.
available.
Right. Or a lot of times with ACT teams, part of what they do is to bring medications to the people in their homes. So if you're not on a shot type of depot medication, maybe the oral meds to make sure people are taking those well. I might be checking on your medications, but I'm also going to work with you on your budgeting or something like that.
Yeah, it's also about like the ratio of each team member and its clients, because somebody that's giving the medicines needs to meet for, I don't know, like 10, 15 minutes, and somebody that's looking for a job needs like 1 or 2 hours.
Right.
So like scheduling the time load.
Yeah, and that's part of what the morning meeting can help do. And the manager's role is to make sure, oh, Joe needs to go to the grocery store today. That's going to take an hour and a half, and maybe I don't have as much time, so Mary's going to take him to the grocery store today, and I'm going to go deal with this person. So they kind of try to shift based on what the client needs.
Okay.
Does that make sense?
Yeah, and what about client-provider relationships and the difference between?
Yeah. So I think that still becomes an issue. So the ACT team has the shared caseloads, and the idea is that multiple staff will see a particular client. So maybe teams usually set it up as kind of like mini teams. Maybe these 3 people see this client. So the client gets to know all of them. They might have a favorite. They might have a better relationship. But if that person is sick or goes on maternity leave or has a family leave, they already know those other people who've seen them a lot and they feel comfortable with them. Maybe they're not as close, but they know it's not like a total stranger saying, oh, now I'm stepping in and you don't know me. But I think teams do sometimes struggle, especially when you're switching from an individual caseload to the shared caseload. There is a lot of that sense of, I have this relationship, they're my client, I'm responsible, and it takes a while to kind of shift to that idea that we as a team are serving them, and it might be helpful to have different perspectives who could help them. So that does become a shift that people, their mindset has to be from individual to shared. And clients typically like it. I think I have a brother who has schizophrenia too, and he would have people on his team. There were some people that he was really close to and he liked better, but he still liked that people were checking on him and that he felt like there was a group of people who knew him. And so when his substance abuse specialist on the team left, there were other people he still felt comfortable with. Whereas when he's in a more traditional setting, he's now not in an ACT team. He moved to a different state and they do things individually. When that case manager left and a new one came, it was hard to get to know that person and trust them. And so I think there are some real strengths about having this team approach to the relationships. Yeah?
On the same issue, it sounds very dynamic when you describe the day in the life of a team, and I'm sure there's a lot of advantages for that, but isn't it an issue for the consumer, this dynamic, that it seems like in the morning it doesn't know who's the person who's going to come by in the next hours to accompany him for whatever, the grocery, or the doctor or whatever. Is that been an issue from your field experience? A complaint from consumers that it's too dynamic, it's too
many people. I think that's why teams move to these like mini teams. So it's not all 10 people seeing you. I don't rotate through 10 different people over the next 2 weeks. That would feel like too much. But maybe it's the same 3 or 4 people who see me and they know. But they usually tell ahead of time, like they'll say, oh, you need to go to the doctor this week. I think that's going to be Mary who's taking you. And so the person does have some sense. But in the morning meeting, if there is a crisis or something that occurs, then they have to make those shifts. And they might call the client and say, I was going to come today, but I'm not going to be able to. But Joe's going to be there, and he's going to take you. And you already know Joe. And so it's not that big of a deal. Yeah. Yeah.
In the cost-effective budgeting perspective, is there like a minimum amount of members of a team that is needed? If we want to implement it here and there's a low budgeting possibilities, maybe instead of 10, only like 5 people. Who will be the 5?
The 5 people. So we have done some studies. We did some rural studies early on where they didn't have as many clients and they didn't have as much money to fund a team. So they funded 2 people and a doctor, and that wasn't enough. That wasn't enough to actually get the full continuity of care and coverage, and in these rural areas they had to drive a lot, and so I would say 3 is too small. But the bridge teams, what we called them bridge teams in Chicago, had maybe 5 to 7 people on a team. And they tend to work pretty well. So maybe their whole caseload would be 50 to 70 clients. And then have a smaller 5 to 10, or 5 to 7 people instead of 10. So I think most teams, even if you had a lot of money and you could have a lot of staff, you probably don't want more than 100 to 120 clients served by one team. that becomes so hard to coordinate. So if you have more than that, you might want to have two smaller teams rather than one. You don't want one team that serves 200 people. You can't go through the whole caseload in the morning. It'd be better to have two teams and split them. Yeah.
You talked about budgeting.
Mm-hmm.
Do you sometimes get help from finance advisors or legal advisors?
Yes, you could do that. You could have maybe a case manager goes with a client to see an advisor. They sometimes do that. We have something called representative payee-ship. Do you have that here, where sometimes instead of the benefits going directly to the client,
It's more like a legal guardian.
a legal guardian
takes care of it, yeah.
Yeah, so some teams serve that role themselves, but then it becomes often struggles between over money. And so teams often like to have the representative payee be someone else, so the team can help you and not be seen as the person keeping your money away from you. So there's sometimes that. But you can go to other advisors and to get help, to get input, I guess, see financial advisors. But ideally, the team can develop some expertise themselves, too, around those budgeting issues and provide basic guidance about that. I saw a hand over. Was it you? Okay, and then I'll take.
How should I say it? We're doing what you're doing here in Israel. There's one team of Abarbanel Hospital.
Okay.
And we've been doing this for 15 years, completely not in accordance with your fidelity model, due to budget limits.
Yes.
Okay?
That
so
often
we don't have 10 team members, we don't have an occupational therapist, we don't have a social worker. It's a 2 or 3 people team, and we do all this with amazing results. However, and this is where the disappointment comes in, I don't see that in the future someone will pick up the glove and say, we're funding this. And that's the key here. You come and you lecture, and it's all very nice. We took numbers from 2 years before we started and 2 years after, and we reduced, or we cut to over 2,000 hospitalization days for those patients, and reduced the number of admissions significantly, statistically significantly. And yet, we're the only ones who are doing it, and most of the people in Israel or in our neighborhood don't know that we do it, unfortunately.
Yeah.
And here's the question, how your visit can promote this, and who can promote creating this service, because it hasn't been done, and I don't see a future.
Yeah.
It will be done.
Okay. I think that is an excellent topic when we do our discussion later, and I do have some slides about how we have done it in the U.S. that I think that there can be learning communities where your team might serve as a model to other organizations. If there is a natural interest, if some of you in the audience are saying, hey, this would be kind of cool, and then can connect with you and say, well, what is it you're doing at that place, and how do you make it work? And having some regular contact among you, you might be able to kind of naturally start spreading these. In the U.S., when we did this national implementation project, states funded little centers to do training and to do connecting with people. And so that might be something that you would want to advocate for. I don't know what your funding looks like, and so this afternoon I hope we can talk a little bit about that and get some ideas for that. So, did you have a question?
I wanted to know, in the ACMA model, how did you deal with the safety of team members, especially female team members, as the ACMA model is talking about going to sometimes to the client's residence or...
Yeah, that can definitely be an issue, and it's something that each team has to kind of figure out how they want to make it work. Sometimes, if there are clients that you are concerned about, you need to think about who is going to be the people who are serving that client. And so it may not be best for a woman to go by herself. Maybe you send 2 staff to that particular client. Or maybe you send the bigger male staff and they can bring the client into a more public setting where another person could work with them too. So I think that each team has to kind of figure out how to make it safe for them. And that for most people on your team, seeing them in the community is perfectly safe. There's usually only maybe 1 or 2 clients you might be worried about. Or when someone is in a crisis point, then you might want to send 2 people or think about how you're going to do that differently.
The manager is responsible for also dealing with this subject or concern that may be raised.
The manager?
The manager, like in the daily meetings?
Yes, so you might be talking about that. Oh, I saw this person yesterday, he's not doing very well. I'm not sure that we should be sending someone alone. So maybe today we need to think about how we're going to do that differently. Sometimes teams you might need to involve the local authorities. Ideally, you have a relationship with them and they know, like we have some training programs. The ACT teams often work with local police to help them understand how do you respond to someone in a psychiatric crisis so that you don't escalate the problem. But sometimes you might need that too. So, yes.
How are you choosing the clients to the program? And you're taking also drug or alcohol user?
So each team develops their own admission criteria of what they will serve. I had the one slide on who do people serve. Usually teams think about things like people who've been in the hospital so many times in the last few years, someone who's homeless. ACT has been set up for people with mental health disorders as the primary. So we don't usually do ACT teams for people who are heroin addicts as their primary thing. But someone may have mental health concern and a substance use, and we serve those people. Yeah. The idea is that the team should have control, like early in some of the ACT models, sometimes in one state they had the state saying, you will serve this person, and this person. And that was hard for teams because sometimes the person at the state who was assigning the cases didn't really understand the ACT model or what it was for. And so having really clear admission criteria becomes important. Thought I saw a hand over here. No? Oh, right there, sorry.
Well, so regarding the question before, maybe adding a martial arts specialist to the team would solve some of the issues. But when does the working day end? That's
yeah.
the question, but it's kind of an issue.
Yeah. So the ACT team may work like from 9 to 5 or 8 to 5. And then they usually have someone who is on call, and they switch that responsibility. So I might have the phone for 3 days for the on-call, and then I switch to someone else. Some teams, like in larger cities where you have many more clients and more staff, might have 2 shifts, so that you might cover one shift works from 7 to 4 and the other shift works from 2 to 8, and so you have some coverage in the evening. I've seen some places have a weekend, like one day on the weekend where they actually do services. A smaller number of people are working. But the on-call coverage is usually shared among the team members.
So partially it's an emergency service, in a way.
Yeah.
You are available during the full 24 hours.
Yeah. And the idea is, that you know the person best, and so that if they call the crisis line, they might not really need to go to the hospital, and you know that person and you can kind of talk them down. Whereas if they call just a regular crisis line separate, yeah, and so that's the idea. And if the team shares the responsibility for the on-call service, it's less stress to the team. Some agencies pay a little extra for the time that you're on call. Did you have a question?
Yeah. How does a person enter the service? If there is a contract, or how does it happen? Like when a person go into the service, and how does it go out?
I'm not sure if places do a contract so much. They do like an intake interview and assessment process and get to know the person. They do have kind of informed treatment statements that the person signs. We encourage ACT teams to have graduation criteria. So how do you know when someone is doing well in their recovery that they don't need these intensive services? What does that look like? And then how do you work with people to transition them off? You don't just come every day of the week and then say, oh, you're ready to go, and then I don't see you anymore. You need some kind of transition plan, and you work with the client or the consumer to see what is that going to look like. Where will you get your care? Often you might not need daily or weekly contact, but maybe you want to be connected with a therapist that you could come see once a month, or maybe you might still want to see the psychiatrist or a psychiatrist. And so you work with people to have kind of a discharge plan. And you do have papers and written plans in place for that.
There's a treatment plan as well?
Yes. Yeah, you'll have a treatment plan. For us, I think for Medicaid, you have to update it every 90 days. And so there's a formal plan that you do. And you do that with the client in the room and together. And so there's treatment planning ideas that you do. Yeah.
How often client sees one of the members?
It could depend. Sometimes they see him every day. Sometimes it's once a week.
It's depend on the situation?
Yeah, and kind of what they need and how they're doing. If they're doing pretty well, and then maybe you just need kind of a check-in visit.